It took a pandemic to realize the importance of healthcare, the importance of investing in it, and the importance of consolidating it. It also took a pandemic for us to realize how, for many of us, access to basic healthcare is still a distant dream. Welcome to Health Analytics Asia, and today, as we mark the 72nd World Health Day, the topic or the theme, building a fairer, healthier world, could not be more pertinent. To discuss India's place in all this, we have with us Professor Shamika Ravi, economist, senior fellow of the Brookings Institute, and former member of the Prime Minister's Economic Advisory Council. Professor Shamika, thank you so much for joining us. I want to start off with your thoughts on the pandemic laying bare the inequalities and the inequities in healthcare access in India as well as across the globe.
Well, Tariq, of course, I think your introductory line was absolutely spot on. It has taken a pandemic to lay bare open, I think, a reality which, of course, many of us who have been studying healthcare sector globally, we are well aware of that inequity. Except now it is very immediate and the impacts are being felt globally. But if you recall in the beginning, a lot of how the pandemic was going to go, it was very difficult for anyone to predict. As you know, a lot of the predictions were also subsequently junked. But it does, health infrastructure is, a lot of it has to do with, also knowledge in terms of research and data. So, trying to make predictions of how the pandemic would go in some of the other countries, like particularly, let's say in India, based on parameters from Europe or China or Japan, I mean, it did prove very naive. And that is why I think, healthcare infrastructure is not just the service of healthcare in terms of, hospital and human resources, doctors, nurses, medication, but also knowledge. I think research in healthcare is also, we don't talk much about it, which seems to suggest that, it's still on the back burner. And while we're in the middle of the pandemic, I think we should seize the opportunity to highlight that shortage. That the less we know, the less we are likely to make precise policy interventions. We are likely to do much more broad brush strokes. And for a large country like ours, where we do know that even simple metrics like beds per million people, number of doctors per million people, there are enormous variations across our states and union territories. In fact, if you look at a state like Uttar Pradesh, then even within the state, you will see that there are certain pockets which have, average availability, but there are many parts which are way below all India levels. So enormous variations, not just at the state level, but even within large states, there are big variations. And I think the time is right to highlight that.
Right. You're right. So on a broader concept of healthcare, accessibility, affordability, and quality are considered the elemental mainstays of healthcare. And these are the exact words that you used in one of your reports last year, albeit in the context of medicines in India. So where does India's healthcare system stand on these three aspects then? Affordability, accessibility, and quality. How do we rate India's healthcare on these three aspects?
So Tariq, we can look at it's, when you start ranking it based on international parameters, then we stay limited to some indicators. And again, it will be beds per million, hospitals, per million. It will be number of doctors and nurses per million. And these are metrics that we have, it is in the public domain. We have talked a great deal about it. But I think we really need to take the conversation below that level as well, especially when we are thinking of access, then access, one is, of course, the availability. What is the availability of, let's say, a primary health center or a community health center within 5 kilometers of where a citizen lives? And the census of India actually gives a decent, estimate of how accessible in terms of physical distance is healthcare to average Indian citizens. Now, the census itself is dated, Because, in a fast moving, a dynamic young economy like India, 10 years and now of course 11 is a long period of time. So I'm sure the census is like a under sort of a estimate. But even if you look at that, then we know that there are very many villages, uh, and many states, let's say, where you have 30% of villages which do not have any health infrastructure within 5 kilometers, for instance. There's no sub center. Now, again, those are broad indicators, but access has to do with more than physical availability. For instance, 75% of our health infrastructure is urban. A lot of that is really certain metropolis. So when we start analyzing data, for instance, from, let's say, the largest public health institution in Asia, which is the All India Institute of Medical Sciences in Delhi, then inequities emerge even if people have physical access, but there are larger inequities. For instance, we estimate that close to 40% of female patients are missing in an institution like AIDS. So, do they have access? Yes, they have as much physical access as, let's say, the men, because AIDS is not, it's relatively free care, it's highly subsidized, and it's available to all. And yet, if you actually look at access to care for women, then we know that the hindrance is at a society level. So access is therefore a very loaded term. I'm sorry to give you a long, windy answer. Then the question of quality. Quality of care is something we have just started looking at that. Because quality of care has to be measured. Now, there are new metrics. If you look at the way health analytics is going, the way we have started, even within, let's say, affordable care, quality can be measured through, there are many different indicators. For instance, what is the readmission rate of patients? Like once they have been discharged, how many of them come back into the hospital? Right? And the higher that number, lesser the quality. There could be just the average length of stay itself. What is the infection rate, hospital-acquired infection? Hospitals aren't as safe as we think they are. A lot of people develop complications beyond what they access the hospital in the beginning. And because hospital-acquired infection is a very big killer.
Right.
So, these are all metrics of quality. In India, unfortunately, while we have looked at some of these indicators for a few hospitals at very perfunctory levels, but we are yet to imbibe these basic indicators and quality measures in day-to-day decision-making of not just public health care, therefore policy becomes important, but also I think governance and day-to-day running, the management of hospitals, where you have to look at the private, the corporate, and how private healthcare is run. So quality has to be imbibed into the basic governance of healthcare, and people must be made aware of it. Just like you are given rating about hotels and you are given rating about movies, quality is very, very important, and those metrics must be calculated and made publicly aware. And affordability was your third question. Affordability, you see, on many counts, we are doing quite well because we are a very large producer of generic drugs. We have also had policies, and many actually progressive policies in the last few years, where generic drugs have been made available more than ever before. So, for instance, the Aushadhi scheme, as per which individuals are being incentivized to open stores where a large number of generic drugs can be sold at subsidized prices. Now, all of this will obviously mean that people have access to certain kinds of drugs. But we know that healthcare affordability goes beyond medicines, though medicines remain one of the largest component of out-of-pocket health burden for individuals.
Right.
And the Ayushman Bharat is meant to improve the out-of-pocket health burden for individuals for hospitalization. But healthcare, costs are rising on account of diagnostics. Healthcare costs are rising for urban area much more than rural area. So those broad inequities within the country will require for us to constantly keep working on the policy interventions to make it equitably and affordable across the entire demographics. Yeah.
Yes, my next two questions are basically a follow up because in India's case, let's say you mentioned the out of pocket expenses. They are in India has among the highest in the world. We are above 60%, I believe, and the global average being 20%. Uh, is universal healthcare coverage in India's case, Ayushman Bharat, the solution for this? And as far as Ayushman Bharat is concerned, what do you think still needs improvement as with regards to the policy as well as its execution on the ground? Because we are a little over 2 years now since the policy came into effect. There must be some feedback, and so what? How is the policy doing on the ground?
So if you remember, Tariq, Ayushman Bharat has two components to it. The health insurance, the publicly financed, the health insurance scheme is one part of it. Unfortunately, that has also captivated the public discourse, and almost the entire media attention is only on the health insurance part of it. But Ayushman Bharat had a second component, which had to do with the wellness centers. And that is in recognition of the fact that, hospitalization and insurance really works at the fag end of the disease, when you are finally hospitalized and the expenses can then be taken care of. But we have enough knowledge now, empirical knowledge, which says that if you can take care of the early preventive and primary care, then subsequent need for hospitalization and the burden, therefore, of hospitalization can be reduced. So if you have stronger primary health care, then naturally the hospitalization incidence and the burden will reduce. That is why the big focus on wellness center. Unfortunately, on the wellness center, financial instrument is much more easy to design. And health insurance is a financial instrument than actually availability of care at the local level, which is what wellness center is meant to achieve, which will require not just physical sprucing up and availability of a good wellness center which has all the equipments, but also manpower. You need enough well-trained nurses and healthcare practitioners to be able to man those wellness centers. So on the wellness center side, I think different states are reporting very different experiences. And they tie in with the old traditional problems of governance that we have had in healthcare. So some states, which have traditionally had well-run primary health centers, are able to make this transition into improving wellness centers easier. It has been made easy there. But in many of our states, northeastern states, UP, Bihar, Rajasthan, Jharkhand, the problems remain. That it is not going to be easy because it is not a real estate business. We can't just construct these wellness centers, but not just equipments, but you need people. And that is our biggest constraint right now.
You also talked about the spending on medicines being a substantial part of the out-of-pocket expenses. And you also mentioned Jan Aushadhi program. Now, Jan Aushadhi program was an attempt in the right direction, and although it still has some gaps. So how do you think India can ensure that this Jan Aushadhi model is improved? And is there a possibility for this model to be extrapolated to provide affordable diagnostics as well? Because right now it's generic drugs. Could it be extrapolated to diagnostics as well?
Well, clearly the model that is emerging, a large part of diagnostics is in the private sector. Now, again, it's important to recognize that 75% of OPD, outpatient consulting that happens in healthcare, is exclusively private. So private sector is a very large player in India's healthcare sector. Now, the understanding that people are entrepreneurial, and if you basically give them a simple business idea and the incentive to set up these stores, then there are people who will come forward and use this opportunity to set up these businesses. Now, it's very early still to see what is the impact, but we know that a lot of shops have opened. Again, they have opened in places where the market exists, right? Because you still have to go and buy these generic drugs. So when there is a business opportunity, when youngsters are seeing that opening of a Jan Aushadhi store is going to give me a certain cash flow, so it becomes an acceptable livelihood model. Which means, these are townships. These are places outside the cities. These are townships. We have still not really achieved this kind of outreach in the remote areas.
Right.
Because that is where the markets are still very, not well developed. So if you don't have a significant demand for this and people having sort of the capability to pay for these drugs, then naturally those shops will not open there, which means the dependence on public pharmacies and public hospitals and primary health center and community health centers to disperse medicines will remain pretty high, right? So it's a good model, and I think it has achieved in terms of opening, but in terms of sustainability, can the Jan Aushadhi store really become a acceptable livelihood model for a very large number of people? Yes, it has become in areas where the revenue is decent. But again, the remote areas, connectivity problems remain. Market is small. So those are places, again, they are underserved relatively. Can it be extended to diagnostics? Well, diagnostics, unfortunately, is not as standardized as medicine, which means that, again, it will require manpower. Will require trained people. It will require the back end, the lab support, because diagnostic also requires, a longer sort of a logistic support. All of that become right now an impeding factor. But diagnostics, I mean, it will definitely work in the big cities. It will definitely work in tier 2, tier 3 cities. It might still not be a sustainable model in the villages, but definitely worth experimenting.
Okay. We talked about shortfalls, manpower shortfalls, quite a bit. And there were reports last year or a year before that the NITI Aayog was proposing a move to associate medical colleges with the district hospitals, and that was based on a PPP model. Do you think a PPP model, along with an associated medical colleges at district level, can solve the shortfall of personnel problem and can also ensure quality of care while still maintaining costs, while still maintaining low costs?
Well, given that manpower is our biggest constraint, Tariq,
Yeah.
we will have to produce more human resource for the healthcare sector, right? By the way, that includes not just doctors and nurses, but it requires a whole range of specialists, which also includes health IT. The kind of people who are required to enter health data into the HMIS, the Health Management Information System, within a hospital. So we are looking at expanding manpower in all areas of healthcare. That's number one. Will the model of transforming district hospitals into medical colleges work? I think it will work in those district hospitals which have the capability, which have the scale. Remember, a certain minimum amount of training is required for an MBBS degree as well.
Right.
So unless you have all those the required departments and faculty, it becomes difficult to achieve. Now, in many of our districts, our district hospitals do have, the scale and sort of the complexity. If you look at the departments and the number of specialists, doctors who can also teach, several of them can be transformed into colleges, medical colleges. But I think eventually we will have cluster models that look across district hospitals. We will have training happen because different hospitals have different strengths in different departments, and that will work as far as district colleges are concerned, district hospitals are concerned. But I think we should also now seriously think of some degree of training in our super specialist private hospitals. India today boasts of some of the finest super specialty hospitals. Unfortunately, they are limited right now in terms of the service, they're really healthcare providers. There isn't much training happening, and yet they do have the scale
Right.
and the number of departments and faculty who can provide this required training. So I think we'll have to work out, and again, support from government will be required, because remember, the doctors who are joining private hospitals are doing as practitioners. I mean, they're getting a salary to really see patients, or they get a percentage or whatever the incentive schemes might be. They're definitely not being incentivized to train people. So for hospitals to really incorporate the cost of training, we will have to come up with a working model. Now, remember, some of the finest private medical colleges are also very good hospitals, right? So, I mean, we are seeing this is happening in a lot of, the chains, hospital chains, particularly in the southern part of the country. So, I think we have enough models that have emerged through trial and error, that there are some that can be scaled up now. So the PPP model, I think, really does have, merit, and I think we must try and bolster that.
I want to briefly steer this conversation a little towards the society and the social aspects of healthcare in India. You touched upon the issue of gender discrimination, and I want to refer to a study that you co-authored in 2019 with regards to gender bias in tertiary care in India. How big of an issue is it for India going forward in the next 10, 15 years? Gender bias, how big of an issue is it?
Tariq, I think it is one of our single, it's the biggest problem, not just from the healthcare perspective, but from the broader gender perspective. One of the reasons we don't fare very well on gender equality indices, and there are many indices, but whenever gender inequality is studied and human capital is a part of that, meaning health, education, we do pretty badly. And one of the biggest reasons for that is access to healthcare. And I'm glad you mentioned the role of community, because clearly what these studies, what the data from our public hospitals are reflecting, is that even when care is cheap, affordable, and close by, so physically accessible, the community, the society discriminates very strongly. Because when we saw that 40%, more than 40% of patients are missing, which means that AIMS should have ideally had almost twice the number of women patients than what is currently having. And that study removes gynecology, obstetrics, etc. So you're really looking at ailments where there is a certain degree of parity, right? But when you look at discrimination, so you look at the sex ratio of the patients, then it is quite systematic. That as a society, we tend to take very few young girls and older women to hospital. In fact, women's access to hospital is best during the reproductive age. And remember, so the study is removing gynecology and obstetrics. So it includes everything else. So women at very young age and older age are very strongly discriminated against when it comes to healthcare. In fact, for younger girls, we have seen that twice as many boys are brought to the hospital than girls, twice. So the sex ratio is more than 2. Now, clearly, that reflects it's not a cost. It's not you see, the policy intervention is no longer from the government. It really is something that we have to address within the household. The government has a limited role, unless we say that let's make it even more, even easier to get women. How do we do? Maybe we can run special buses. Maybe, the protocols within AIMS or within the district hospitals can be improved for women, that you don't need paperwork. If women come immediately, basic screening can become. We can do some things, but that is not enough if the household, the family, the community discriminates in such deep ways, right? So I think this is a very big problem which will require for us to deal with it at a multiple sort of level, not limited to policy. We have to go to the community.
Do you also think prevalent biases and taboos in the Indian society, including ones on gender roles, mental health, and old age? Do they impede heavily with efficient delivery of healthcare?
I'm quite sure. I mean, if you just look at the suicide data, and I've been looking at the NCRB data for the last 15 years, the largest demographic, if you look at the largest component, fraction of suicides, is by housewives. Now, forget the policy part of it. If we now begin to think of, uh, access to healthcare for housewives. Housewife is also a loaded term. I mean, you could be a housewife and doing multiple things, but the fact that the NCRB data is consistently for the last 30 years showing that housewives remain the biggest component in suicides in India. Mental health is a very, very big problem, right? Because suicides are directly linked to mental health. So, what is the access to mental health for housewives? And housewife, by that, you should also extend it to women by and large. So, mental health, I think, and the suicide data is quite compelling in terms of thinking of access, affordability, quality, etc. that you have raised. But the NS's data also tells us something quite fascinating. If you look at people who report being sick, then women generally tend to underreport health issues. And that is again consistently coming out that for similar ailments, women tend to underreport illnesses. Then other studies that we have done, for instance, from microfinance clients who are people around poverty line, and when you try and see, well, even if you have health insurance, do you file claims? And we see systematically that wives of male borrowers generally, they don't even know they're not filing claims, which means they're not, I mean, they can't be not falling sick. But women, they are empowered, meaning when they are borrowers of loan, then they are filing claims because they have health insurance. They know they are financially literate. They know what health insurance is. But for a large number of women who are spouses in the system, and that is how they are covered through health insurance, they are not filing claims at all. So that extends the argument to access is also linked. It's a measure of empowerment. That if you are covered and you're still not filing claim or you're not using health insurance for women, reflection of lack of women's empowerment. It's for me as an economist, we measure things, right? And having health insurance and still not filing claim, and systematically it being the case for women who are spouses rather than borrowers of loans, is an indication of lack of empowerment. Then who makes decisions whether to go to the hospital, how sick are you, etc. Mother-in-laws are usually, a lot of sociology literature, this is now old knowledge. People know that the decisions aren't made by the women themselves. They don't have the agency. It is made by older women in the household. It is made by the head of the household. Many times they are men. So there are deeper societal inequities that needs to be addressed.
True. Shuffling a little bit towards the context of this pandemic and the ongoing vaccination drive. In India's vaccination drive, there are several names that seem to be missing. Pfizer pulled out of the approval process, and there's also no real word on the Tata Moderna alliance happening either. Why do you think these much needed vaccines and these big vaccine companies have thus far shied away? Is there a lack of incentive there as well?
It's very difficult to answer this. These are now speculations.
Mm.
The fact that Pfizer did not apply, the fact that currently we have two that are in the market, which means that is being actively administered, but we also have a pipeline, right? Novavax. Now we have talks going on about Sputnik, I think, has
Sputnik, yeah.
now been applied and so on and so forth. That the knowledge or the information about what vaccines have applied for emergency usage, what is the data put forth, and who has been denied, and whether it is commercial aspect, or is it the fact that since their trials have not been conducted on Indian population, so we don't know the exact efficacy of these, that information is just not public. And so against that lack of information, it's very difficult to speculate, right? And frankly, I will stay away
Right.
from speculation on specific pharmas and why they're not in the market.
Okay, so a little broader then. Price control, you call it a double-edged sword. Uh, so your thoughts on price control of vaccines, diagnostics, and treatments in the middle of a pandemic? What are the pros and cons of opening up the free market to, let's say, vaccines or even treatment facilities or diagnostics as well?
So I think there are some, you have to look at it from fundamental reality of India's market. Number one, 75% of India's healthcare is private.
Yeah.
Number two, medical tourism is one of the fastest growing businesses in India, which also, of course, is from the fact that we have some of the largest super specialty hospitals, where willingness to pay, of course, it is willingness to pay in terms of what is the demand for healthcare. But we have a large market segment which does demand and has the willingness to pay for, let's say, an expensive vaccine, or doesn't feel the necessity for a subsidized at cost vaccine. So I think recognizing that reality, we can perhaps design ways of cross subsidization, that those who can pay more, and that can be used to cross subsidize those who cannot pay, right? But remember, this is an infectious disease.
Right.
This is not like getting a surgery done to an individual. Communicable diseases means that one person vaccinated also makes it safe for others around. So there are externalities, and therefore, the opposite is also true. When the infection spreads, and not having vaccinated people impacts not just that person, but others around. So against this reality, which is why you have seen that large vaccination drives have often been free, because that it's a public good, because there are such vast externalities that we want to take care of it at a universal level. We want to really contain this infection, and cost, therefore, the way the policy seems to have been designed is that the scale of the purchase is so large, and remember that the unit cost is quite low, though we don't have a breakup of exactly how much one unit of one shot costs. But the scale is so large that the current prices that have been set up is in accordance with what the WHO, the Covaxin initiative of $3 that was set up. We are still, sort of meeting that constraint, and it seems to be viable. So yeah, unless you have again details of what will be the cost of now the administering the vaccine in private hospitals, and if private hospitals are now finding it difficult to vaccinate people at the current cost, then I think it needs to be revisited. But currently, I don't think that is a main concern, unless, of course, the private sector makes a representation. We aren't seeing that very much. I mean, we know that almost 90% of vaccination is being done at public care, and we do know that this must be ramped up.
Right.
But we don't know that it's not being ramped up because private hospitals aren't doing enough, or there is actually a constraint on the availability of the vaccine itself.
Right. Okay. So now data has seen newfound importance over the course of this pandemic, and over the initial weeks and months, you used to put out daily updates, and I must confess, I used to follow that very closely as well. How do you see data and technology in general help in bridging the healthcare gap in low and middle income countries?
I think data analytics is helpful for all, Tariq, but it becomes particularly relevant for low income and middle income countries. And the reason is because your resources are scarce. Now, even in the current setup, think about it. When we talk of all India level statistics, it's quite simplistic. We are a very big country. And the pandemic has never been uniformly bad everywhere. Or it has uniformly, it has been good everywhere. There have been huge variations. we can say now in hindsight that this is largely a urban phenomenon, and it has largely been on the Western. If you look at the mortality numbers, then it seems to be, much more skewed. The severity in terms of lives lost is much more on the Western part of the country. But our policies are quite, they are uniform. I mean, we have national level policies, and health is state subject. So there is a lot of variation, and that's why I keep saying that an individual citizen's experience with the pandemic is really determined by my district hospital, my district, or my primary health center in the colony. It is not a function of what the central government, uh, announces. I think the central government has a guiding role, and in the beginning, very important one, because protocols were developed, a lot of guiding principles were being developed. And also you're trying to, many places didn't even have labs, right? Testing labs. So in the first several months, I think, the way the states were working in tandem, I think a lot has been achieved in terms of bolstering the health infrastructure. But in today's day and age, I think health and, health analytics can help us make more precise policies. Which is the district that really is seeing an escalation? Why should we go into a state-wise lockdown if the numbers are really in a few districts in that state, right? Then think of vaccinating in terms of comorbidities. Right now we have still very broad set of, right? I mean, age brackets. We have 45 and above. But then, in India, we also know from the data that comorbidities, hypertension, etc., diabetes, the onset happens at a much younger age than it happens in, let's say, Europe. So 45 to 55 is when a lot of Indians, they develop hypertension and diabetic problems, etc. Now, we also know from evidence that it is going further down. Now, 30-year-olds have hypertension. So data and analytics can help you fine-tune policy interventions, and particularly for resource-poor country like ours.
Okay, before we conclude, a couple of final thoughts from you, Professor. You have in pre-pandemic days considered health as one of the driving forces for the Indian economy for the next 100 years, education being the other. How will a post-pandemic India ensure that health stays as its driving force, and can it still rebuild on its strengths and potentials?
Oh, Tariq, I think health has to become political. People have to demand better health care. We know that the out-of-pocket health burden is quite debilitating for people, right? We know that if you look at catastrophic health expenditures, we have a very large proportion of population that spends a lot of money on healthcare, as a monthly expenditure composition. And I think it should not be a battle between, individuals and the hospital. It has to be a society level effort. And that is why I think demanding better healthcare, more affordable healthcare. I think healthcare needs to get onto the manifestos of political parties, right? Till healthcare becomes political, we will always continue to look at policy responses and not major sort of, emphasis. And this pandemic is, of course, it is staring us in the face. The fact that despite having low case fatality rate in India, we've gotten lucky that way. Relatively, we have lost fewer lives per infection. And yet, we've had a very long lockdown.
Yeah.
Right? The opportunity cost of being in this pandemic, even though we are not losing as many lives, is the fact that we are losing, economically, we have lost a lot. And we continue to do that with the second resurgence. And that's because our healthcare is not prepared for this kind of a surge. And not just the pandemic. Remember, tuberculosis is one of our biggest killers.
Right.
India, we have been living with infectious diseases for many decades now. So COVID is not a new, it's an unknown problem, and we are learning about it every day. But infectious diseases is something we have been struggling and sort of combating for a very long period of time. This pandemic should therefore be an opportunity to get over some of our fundamental problems in health. Right. We have to make healthcare more equitable and affordable
Right.
and available to all. It is a basic right.
Okay. And finally, what are the top things, the top three or top two, whatever, and that, let's say we are smack in the middle of the second wave. What are the top things that India needs, India's healthcare system needs to get right and get right soon rather than wait for it?
Well, one is we have to improve the public health care.
Mhm.
Some states are good at it. Uh, some states are not good at it at all. In fact, if you look at the data, then we see that this fallacy, this belief people have that private care is for the rich and public care is for the poor. That is absolutely a myth. That's not borne by the data at all. We know that in states where district hospitals are well run, the rich and the poor, across quintile groups, people go to district hospitals because there is innate faith in government hospitals and in public health infrastructure. And in places where government hospitals don't work, even the poor go to private care. Okay, so it is not true that we can take care of our big hospitals and the rich will go there and the poor will go to district hospitals. District hospitals and the overall public health infrastructure, right from sub centers to our super specialty tertiary care hospitals like AIMS and all, they need the resources, not just in terms of money and equipments, etc., but people. We need to overcome the shortage of manpower on a urgent basis. I think that has to be the priority number one. Number two, we need to get a better handle on private care. Our private care is growing very fast. It is doing well in terms of certain, component, but the regulatory oversight required
Yeah.
is now needs development. I think we really do need good regulators. We cannot treat healthcare like vacuum cleaners, in terms of consumer protection. It can no longer be, it is not like any other service because there are huge asymmetries in information. We are also seeing that there are deep inequities emerging between public and private care when we know that close to 12% deliveries in public care are C-section, and by nature it mandates that around 10 to 12% deliveries get complicated, so cesarean section is conducted. But in private care, in some states, that number is as high as 36%. So clearly, we know that the incentives in the private healthcare sector, while it can do a lot of good, it can also do a lot of harm. And I think the need to regulate, and that is where, again, the quality metrics that you were asking about earlier, we need to have better patient level data. We need to assess the quality of healthcare in different hospitals, public and private, and people need to be made aware of each of these places when they go and they seek care, that where exactly, what are they getting for what they are spending.
Okay, thank you very much, Professor Shamika. It was lovely speaking to you, and this was indeed an insightful conversation. Thank you for joining us.
Thank you, Tariq. Thank you for having me.
And for all of us, all of you watching, thank you for joining. And until next time, take care and bye bye.